Well, the new treatments in chronic lymphocytic leukemia have become relatively well known, although they have only been introduced less than 6 or 7 years ago. Initially, the new drugs developed to inhibit B-cell receptor, which first one was the Ibrutinib, which is a Bruton tyrosine kinase inhibitor, came out as an oral drug and unbelievably effective in people who had previously failed all standard therapies and had no hope for themselves. And Ibrutinib indeed melted away the large, bulky lymph node enlargements, spleen enlargements, and reduced the size of the amount of lymphocyte infiltration in the bone marrow. Initially, upon starting the drug, Ibrutinib caused an further increase in the number of lymphocytes in the circulating blood. But with continued treatment, several weeks or even months later, not only the lymph node size continued to decrease, but the high number of lymphocytes in the blood also started to decrease. So that it was truly a major response which has been lasting for as long as we continue the drug. So the Ibrutinib advisory is that as long as there is evidence of continued benefit, to continue with the drug. The important thing is that it is not an intravenously given treatment, it is orally given treatment. The second drug, also in the same series of inhibiting B-cell receptor, is Idelalisib, which is a PI3 kinase inhibitor, also an oral drug, and also highly effective, but perhaps not nearly as successful as Ibrutinib. However, both the drugs were initially approved by the governmental agencies for relapsed and refractory CLL. Eventually, Ibrutinib also received approval for frontline treatment of CLL. Therefore, in the front line, it is Ibrutinib, and in relapsed refractory setting, both Ibrutinib as well as Idelalisib. The particular advantage with Ibrutinib also is that those patients who have a bad prognosis disease called P17 deletion or TP53 mutation, those patients also respond to Ibrutinib. Therefore, as I said earlier, development of Ibrutinib has been a major improvement in our ability to treat CLL. The next major improvement came about few years after Ibrutinib and Idelalisib, and that was the development of BCR inhibitor Venetoclax, BCR is overexpressed in CLL lymphocytes, and it protects the cell from apoptosis or programmed cell death. Therefore, these leukemic lymphocytes with the high expression of BCR live forever. And Venetoclax antagonizes or inhibits BCL-2 and thereby causes cell death. It is another amazing improvement in CLL. It is also an orally administered drug, very effective, so effective that if you do not watch out, you can kill the patient inadvertently, because the cell death with the BCR inhibition is so instantaneous and dramatic that if you do not do with the small dose initiation, you can have kidney failure and other problems from tumor lysis. But once it became recognized that tumor lysis is very difficult and important toxicity, we all became very cautious, and since that discovery there has been no serious problem with tumor lysis syndrome, and Venetoclax is effective even after Ibrutinib has failed, and Venetoclax also works against 17p deletion or TP53 mutation. So those are the important advances. I might add that anti-CD20 monoclonal antibodies, the two that have been known, Rituximab and Obinutuzumab, are effective against B cells, but a new anti-CD20 was introduced, which is a slightly different from Rituxan, which is this is called Obinutuzumab, and it is a type 2 monoclonal antibody. It seems to be more powerful than Rituximab, but ever since Obinutuzumab has been introduced, slowly and not so slowly, everywhere where we have used anti-CD20 monoclonals, we have started to introduce Obinutuzumab instead of OFA or Ritux. So these are the important advances. Other advances which we have to look for in the next few years are CAR T cells, which have been introduced for CLL, but the last few years they have been kept on the back burner for reasons of various logistics, and the concept it still is very valid, and I think that as time goes on we will see reintroduction of CAR T cells in the therapy of CLL.